Thank you, everyone, for joining today's webinar. We're excited to share with you, finally, to the larger public, a new strategic plan that we've been working on for quite a while here at the PCPCC. Although, I guess by most strategic planning standards, we have executed this pretty quickly, but we're super excited to share it with you because we really feel that now the PCPCC is positioned in partnership with all of our members, executive members and general members and our other critical partners and thought leaders to really help turn up the heat and move the dial on primary care, really start to realize this vision for primary care that we've been talking about for a long time. So, you know, we've got a lot of these pieces in place, and we've seen this great onboarding and excitement around this model of care among health plans, among policymakers, clinicians, but I think now we're really at the cusp of making it happen in a way that we haven't seen before because of these critical factors and again, relationships that we really feel that are so very important. So we're excited to share all this with you today. This presentation will be available for download on our website by tomorrow afternoon. So if your colleagues were not able to join today and you'd like to share this information with them, we would encourage you to direct them there, share the link. We will be offering an opportunity for you to provide your own comments or questions. So at any time throughout the presentation, please do go into that question box, type your questions. We don't take live audio questions, but at any time start writing in your comments and your questions. And then at the end of the presentation, we'll have a chance to read those off. I'll be asking them of our presenters and respond to those that I think I can. And if we run out of time or if there's other questions that you'd like to ask us offline, please don't hesitate to shoot us an email at any point. I think, Marci, you might be back on the audio now?
I'm trying to be. Can you hear me now, Amy?
Yes, yes, we can hear you now. I'll turn it back over to you.
Oh, terrific. Thank you for hopping in, and my apologies to everybody. I thought I was kicking off a great webinar, but apparently only to myself. Thank you again, everyone, for joining us. We are very excited to share with you the work that we've been doing over the past several months on our strategic planning efforts, and we're particularly excited to have so many leaders from the PCPCC joining us, and I will be introducing them and handing over the reins as we go through our presentation today. You'll see both Amy and myself here in our slides, and I would just want to acknowledge Amy's leadership. As many of you know, we call her the heart of the patient-centered medical home at the PCPCC. And of course, thanks to all of our staff who have been working tirelessly on this project, particularly the Director of Programs, Tara Hacker. Next, I'd like to introduce today's speakers. Brad Thompson, Dan Lowenstein, and Bill Warning are all well known to many of you. They are longtime leaders at the PCPCC. I've provided you with a little bit of their background here in the interest of time and in wanting to get to all of your questions. I won't go into great background on their bios. I will just say that Brad helps serve as the director for the Patient, Family, and Consumer Center at the PCPCC, and he has been doing this a new leader, but has long been a volunteer with the PCPCC and showing us what it means to be patient-centered. And we thank him for his efforts. Dan Lowenstein is also new in terms of co-chairing one of the centers, the Advocacy and Public Policy Center. But as you all know, Dan has been working with us for a long, long time, helping direct us, particularly around state advocacy activities, and in his leadership role, pushing for community health center participation in the medical home movement. And last but not least, Dr. Bill Warning, who, as you can see, is the director of the Family Medicine Residency Program at Crozer Keystone. He has been a longtime co-chair of the Education Task Force, and he's going to be talking about some of our work there. He has recently joined as the co-chair for the Care Delivery and Integration Center. So thanks to all of them who will be joining us in today's call. I'd like to start with just leveling, I think, the playing field. On today's call, I know many of you have been members of the PCPCC and are well aware of our work, but for folks who are just joining us, I'd want to share with you how we define the problems and why we think the patient-centered medical home and advanced primary care are key to the solutions for improving the U.S. health system. As many of you are well aware, the current system has many flaws. Very hard-working health professionals who are trying to improve care for patients, families, and caregivers. But unfortunately, our current fee-for-service system has many inherent flaws. We start with viewing the world through the lens of patient and families who often find the healthcare system, as mentioned on this slide, intimidating, difficult to navigate. For many folks, it is expensive, it's unaffordable, and it's a very frustrating to be a patient or a family or caregiver trying to understand how to get the best care out of a health system that seems awfully confusing. On the delivery side, we've got so many folks who have devoted their lives to providing good healthcare services, and yet their view of the way in which they've often been forced to deliver care is that it's very difficult to do in a system that is very rushed, often over-regulated. For primary care, we certainly feel that we are undervalued, and much of that undervaluing comes back to the lack of resources and infrastructure necessary to provide good care to patients, again, underscoring the inherent problems in a fee-for-service system, which we'll have a chance to discuss in more detail. For those folks who design our health system or pay for health care, employers and policymakers, they're frustrated with the current U.S. health system because it often seems to be incredibly expensive relative to other industrialized countries. But we often don't see good outcomes as a result of the dollars that we invest in it. So there's a lack of clear demonstration around a return on investment. And just a bit of a data point here that many folks refer to. If all this is true, patients and families aren't happy, primary care and other healthcare providers are unhappy with the system, employers and policymakers are frustrated. How do we fix it? How do we go about changing a very complicated, complex system? And where we would point to beginning this effort is really looking at that overuse, underuse, and misuse of healthcare resources, which is roughly 30% of the U.S. healthcare spend. So we believe that health system transformation, if we want to work together to change the system we've got, we need to focus in 4 key areas. The PCPCC spends a fair amount of its time focusing on the first triangle, the red triangle, and that is the delivery of healthcare services and how we reform them in a way that values primary care. But we also speak to the importance of changing the way we pay for healthcare and how we design benefits. So you'll see that in the lower left-hand corner in green. We believe you've got to change the way in which we train our current healthcare workforce, and we'll be referring to that in more detail. But we wouldn't want folks to forget the importance of how we engage not just patients and families, but also consumers and the public. How do we get them involved in this transformation? All too often, they don't even know where to begin. Many of them, in fact, might think our health system works just fine until they find themselves, they or a loved one is sick. So we believe that the need for better primary care, that the evidence speaks clearly to investing in primary care and doing a better job investing in a relationship between a trusted healthcare provider and a patient and that patient's family or caregiver moving us away from the way in which we currently often offer healthcare services, which is really around a sickness care system. You see on the left-hand side, the fragmentation, often driven by specialties. We've got patients that are isolated, but information about those patients is isolated. We manage how they use healthcare services instead of look at the best use of resources from an evidence-based perspective. I've mentioned the word fee-for-service a couple of times. We'll talk about that more here in a moment. We pay a lot for more care instead of better care that is of higher value. And much of the health system feels very adversarial. It's patients and families versus health insurance companies versus the payers, health insurance plans, or employers, and we have an attitude that is really everyone needs to look at their own best interests. We believe that when you invest in primary care and you think about managing populations of care in a collaborative fashion that integrates data about those patients, that uses evidence-based medicine, that values and shares risk and reward for positive health outcomes, when we pay for the value of care instead of the volume of care, and when we think collaboratively and cooperatively, and thinking about alignment between all the patients, the payers, the providers, and often that can be done through a joint contracting process. We believe that that is in fact the means by which we can get rid of the 30% of misuse, underuse, overuse of healthcare, and we can promote better health at a more affordable price. I've outlined the significant problems in our health system, and we're going to speak briefly about many of the quote-unquote experiments underway. At the top of that list is patient-centered medical homes, which we're going to define here more in a moment. But I would want to point us to the more than 30 years worth of studies that are specific to primary care, and that in fact underscore that when you invest in primary care, you're able to improve quality and manage healthcare costs because you're focused on patients. And primary care providers, being the first point of contact with a patient and their families, are often the most trusted voice to advocate on behalf of that patient and family. So how do you do this work? Where do you begin? What do we need to invest in first and foremost? And how do we get to a place where, in fact, we're advocating on behalf of patients, but we are paying for high-value health care? We think that it begins with the proper infrastructure. And we mentioned here both health information technology that points both to the important role of electronic health records, which are largely still inoperable today, so we've still got plenty of challenges in that space. We point to population health management and the number of electronic tools to help us do better population health management. But we also think of primary care and the infrastructure around primary care as prerequisites to being able to move us toward value and volume management where the health system is concerned. When you properly invest in HIT and primary care, you are able to promote care coordination, asking folks to work at the top of their license. And what we believe that means is you're often engaging nurses and social workers and behavioral health specialists that allow us to help patients coordinate their care across the medical neighborhood and across the community. So thinking about the many social supports that particularly the chronically ill or those patients who are vulnerable need. When you offer those services, when you've built that infrastructure, you're able to start actually tracking in a way that allows us to measure whether we are actually impacting the quality of care, the utilization of care, whether patients are getting engaged in their own care. And when you start tracking that and measuring that, we can tie those measures to reimbursement and start paying for the high value care that we believe are becoming increasingly more prevalent, and in some marketplaces even mainstream. Those are accountable care organizations, certainly patient-centered medical homes, but other value-based arrangements. So what does that mean that the PCPCC does? What is our responsibility in advancing these components of a high-performing health system? We do focus first and foremost on primary care. We believe patient-centered medical homes are, in fact, the best model or one of the best models for advanced primary care. And there are three things that we try to do to really advocate for this high-performing health system. The first is we take very seriously our role of educating all stakeholders in and around primary care and patient-centered medical homes, and that education and advocacy work really is about strengthening public policy that promote primary care, and I'm going to come back to that. We think it's really important that we share the evidence around this model, both evidence that speaks to what's working in a patient-centered medical home, as well as evidence that points to where the gaps are. And there are still lots of gaps and lots of places where we can improve. So you'll see that the Patient-Centered Primary Care Collaborative, or the PCPCC, has a number of different communication vehicles and publications to try to do just that and disseminate results and outcomes. And then finally, if you've never been to a PCPCC meeting, our annual meeting in Washington, D.C. Being the perfect example, you'll see that's where a lot of the energy and the excitement and the really invigorating one another happens when we convene healthcare experts with patients and payers and employers to promote learning and awareness and innovation. So the health system transformation work that we try to do happens in these 5 stakeholder centers, and I've just introduced you to 3 leaders from our stakeholder centers. We focus on advocacy and public policy, on care delivery and integration, on employers and purchasers. We take very seriously our role in the outcomes and evaluation space. We are not researchers ourselves, although some of us have academic backgrounds, but we do want to share with you the results from academic studies as well as industry studies. And then, of course, the role that patients, families, and consumers being the center of the PCMH is paramount. We define PCMH using AHRQ, the Agency for Healthcare Research and Quality. As I mentioned, patient-centeredness, person-centeredness being at the top of that list, but pointing to care that is well coordinated across the entire health system and into the community, care that is accessible and available for patients and families when they need it, health systems that are committed to quality and safety, maximizing the use of health information technology, but really with the use of a comprehensive view of health. That is a comprehensive view within the patient, the person in front of you, looking at their all of their health needs, behavioral health, oral health, focusing on them as a whole person and an individual, but then looking at a comprehensive team to deliver services as well, having a team-based approach that allows for sharing leadership across that team, and that begins with a primary care practice. The pieces, and there are many, all fit together, sometimes more seamlessly than others, but you can see we look at a range from health benefit design to how we design personal care plans, how we manage medication, which is critically important for patients, particularly those who are chronically ill. We care about cultural competency. I won't read this slide to you, but you can see we focus on a number of different components that we think make up a strong patient-centered medical home. And we think the outcomes speak for themselves in terms of overall cost savings, in terms of more appropriate utilization of healthcare services, both by reducing the number of emergency department visits, as well as hospital visits. We think that PCMHs improve access. They can improve overall health and population health. There is evidence for improved patient as well as provider satisfaction. And finally, the use of increased preventive services using the health system at the right time, at the right price, and in the right place. We map these innovations at the PCPCC, and we have an extensive amount of information that you can access when you click on our map. Please, if you've never gone to our map, we would say that this is sort of the highlight of what we do in terms of trying to have one-stop shopping, that data and evidence with what states are doing, with what the feds are doing at a national level, and all of the collaborations that are taking place. Please go and look at your state and see what's happening, and collaborate with the other folks who are like-minded, wanting to do this work in your area. What you'll see when you look at that map from a 60,000-foot view is that the momentum for the patient-centered medical home or advanced primary care is indeed growing. It's been embraced by private commercial plans, and we list out many of the folks who are leaders in that space. It's been embraced by employers throughout the U.S., and we list those as well. The public sector and leading from really the space of Medicaid over the last decade, but extending into the federal government with Medicare getting into the game. But we've got the federal employee health plan as well as the military demonstrating real leadership in this space. And hats off to the practices who do the hard work each and every day that really operationalize the patient-centered medical home. The trends in terms of the environmental landscape are quite impressive. There are so many both commercial as well as public sector innovations that are testing and adopting a new payment model that support advanced primary care. This transformation is quite impressive, and again, the map being one of several places where you can go and find resources. I would also point you to AHRQ's website, a tremendous set of resources regarding how to do this kind of transformation work within a practice, as well as pointing to the scientific evidence. I would also point you to NASHP, the National Academy for State Health Policy, that tracks state work, and yet with all of the excitement that we see around PCMH, it's important to recognize that there are folks who are still skeptical, and deservedly so, in that this is a very expensive health system we have, and we've got to demonstrate our ability to change that cost curve. And so our strategic priorities seek to do just that, and demonstrate that not only can we save money through a patient-centered medical home model of care, but even more importantly, we can improve the patient experience of care, and we can improve population health outcomes. A fourth, what you sometimes hear, Quadruple Aim, refers to the important element of improving the lives of the healthcare providers who day in and day out are trying to deliver this care but often feel frazzled. So evidence is building that this model of care also improves their experience. You'll see we seek to do this, and I'm not going to read to you these four strategic priorities because we're going to drill down with more specificity into each of them. And we're going to start with Dan Lowenstein, who's going to speak to priority number 1. Amy's going to talk about priority number 2. Brad, priority 3. Bill is going to speak to priority 4, and then we'll circle back together and open this up for Q&A. So starting with Dan, who's going to talk about the importance of increasing our investment in primary care.
Thank you very much, Marci. First, I'd just like to say PCDC is a proud member of the Patient-Centered Primary Care Collaborative. This really is the national organization that is focused like a laser on advancing high-quality primary care in the medical home model across all professions, across all industries, across all sectors. So this is where the action is, and this is where we're going to try to make it happen. As you can see, there's a great deal of activity, momentum, and evidence around the medical home model and advanced primary care. We have to remember, though, that this movement is still in its infancy. Primary care right now makes up only about 5% of total healthcare spending by most accounts, and that's why 60 million people lack access to primary care, why we have such a huge shortage of providers, and why we lack the infrastructure necessary to scale and get the broad impact on healthcare costs and quality that we all need. This is really because for decades we've invested in a high-cost tertiary care system at the expense of higher value, higher impact primary and preventative care. And we can draw some lessons really from the energy sector. Most people realize that solar, wind, and other renewable energy sources can have a major impact on energy costs and climate change. There are innovations in those sectors too, but they make up only a minuscule slice of energy spending. A major investment is required to bring them to scale to have the desired impact. So our first priority must be to increase investment in primary care, and that means increasing resources allocated to primary care. It means shifting from fee-for-service, which effectively penalizes primary care since it's paid so little on a per-unit basis, to value-based models, which compensate providers for their value to the patient and to those who pay for care. And finally, most patients today are at the mercy of the healthcare system, and for harried primary care providers, the care usually starts and ends with the visit itself. Not always, but usually. With the right tools, training, and incentives, though, primary care providers can be responsible for coordinating their patients' care, improving the experience of care, and improving the health of the populations they serve. Okay. So to accomplish these goals, the PCPCC over the next several years is going to work with policymakers and key stakeholders to strongly advocate for primary care, for payment reform that rewards value over volume and recognizes the value of primary care as central to these models. To define comprehensive primary care so that it can be adequately compensated by payers, and to develop methods to measure primary care investment so that we can get a more accurate picture of who is paying what they should be for primary care and who is not, and then take steps to get more to pay in that way. And finally, as Marci mentioned, to engage the public and to engage employers, because payers will only pay for what their customers think is important, and that's why primary care has gotten such short shrift. Getting patients and employers to understand the importance of primary care to their health and to the bottom line is absolutely critical to success. Back to the energy analogy, primary care is to the healthcare sector really what solar and wind energy is to the energy sector. It's primed for growth, it's full of innovation, it has the promise to catalyze enormously positive change for society. But without strong policies and without sufficient resources, we'll never see the change that we need. So we have to ensure that there is sufficient investment in workforce, education, training, and infrastructure, and other things. And that's why primary care investment is really a key PCPCC priority. And now I'd like to turn it back to Amy Gibson. Thank you.
Thanks so much, Dan. Yeah, and it's really going to be a challenge, I think, for all of us to figure out, what's the right formula and what's the right timing for all of this to happen. So my slides got a little bit ahead of me, so I think we're on track now. But this priority 2 is so important to not just what Dan was talking about, because we need to have the right payment models in place, the right incentives in place to really realize this kind of care that we talk about in a patient-centered medical home. But then there's some people saying, well, we want to first have that transformation in the way we're providing care so that they can participate in these new payment models. So in some ways it's kind of a cart-horse issue, but they really have to be working together synergistically, and we know that there are going to be additional resources needed for true clinical transformation and integration across the medical neighborhood. So this priority 2 really encompasses a lot of that work. And as you can imagine, all of you who are working in this area, you know how hard this work is to do, and there's a lot of different elements to go into it. So we're going to be working very closely at the PCPCC with all of this work that's happening around the country to really change the way we're designing care in the primary care setting and across all of the subspecialists with home-based and community-based services, and of course, most critically, in partnership with our patients and families and caregivers. So one of the first things we're talking about in this is how do we really explain and understand what are those core elements of care delivery and care redesign that constitute a patient-centered medical home. And there's been a lot of work in this area, and as Marci discussed, you know, a lot of the evidence is starting to come forward, and we're starting to get a better sense of what are those key, absolute, critical functions within a primary care practice that define them and make them a medical home. We know that this is a journey. There's never an end result. It's ongoing quality improvement. But, you know, at what point do practices move along that evolution and really start to realize this overall transformation in the care that's designed? So we're going to be doing a lot of work with many partners to make sure we have a cohesive understanding of what all those elements are that go into it. When we talk about this integration, a lot of the things that we're going to be doing are going to be identifying not just key features within the patient-centered medical home, but what's happening within these new payment models and these new integrated relationships, and especially, you know, there's a lot of talk still about what's going on in ACOs. We know it's not sufficient within an ACO model to just have primary care as a part of that ACO. We're really looking for ACOs that are demonstrating success by improving their resource allocation of primary care, how they're doing quality improvement in primary care, and how they're connecting patients within that ACO model to a strong primary care team. Marci also talked about population health in primary care. And so much of what goes into this as well is really ensuring that there's this comprehensive primary care that's happening. How are we fully integrating all the various elements of primary care, including behavioral health, oral health? How are we using technology to the best ends, not only for interoperability and sharing of information, but managing those populations and better identifying where the needs of those patients lie at the right time in the right place, and everything that Marci had described. And then finally, those important, very critical clinic-to-community linkages. This is an area we did a lot of work on in pediatrics when we were developing the idea of a medical home. It's really thinking about what's happening with patients who are most of the time outside the primary care practice, where they work, where they live, where they go to school. These are all such absolutely important and critical elements to ensuring that patients have the right resources and support when they're trying to realize their health goals. And so we're going to be talking more and working at the PCPCC with many partners, including the Ys, including Meals on Wheels, including the Triple A's. There's so many individuals who are doing this work, and certainly amongst public health and other sectors that have not often had a close relationship with primary care. So just in closing, I think we're very excited at the PCPCC for all the work that's coming out, and we're going to see a lot more resource and development in this area in the next couple of months. So I want to encourage all of you to share your experiences and questions with us too in terms of how you're going to be doing this at your organization and moving this forward. So now I didn't want to steal your thunder, Brad, but I'm going to leave it to you to really talk about how the PCPCC is going to be supporting the role of patients and families as key partners in all of this work, especially clinical transformation.
Okay, thanks, Amy. We will do our best. It's a real treat for me to get to be on this call with those of you who are listening, and I'm thankful for this group of people that is so committed to really what I think is moving a care that is done to patients with to moving it to with patients. And so as we do that, I think it's really important that we begin to focus efforts of education onto patients and families and consumers that allow us to understand that we are really the true experts of our life. There are a lot of people in the medical world who know more about the diagnosis or whatever that we're experiencing, but we are the people who know where we're trying to go and where we're trying to get. And so I think it's really important that there's at least a part of the work that we're doing that is encouraging and empowering patients and families to really be engaged and involved as the medical community is looking to ratchet up our engagement with them. And so as I look at this, I see the primary care movement being the way to really get the biggest bang for our medical bucks. And the best way we do that is to take advantage of all the resources that are available, especially at the primary care level. And I think patients and family members have a great opportunity and a great gift of knowledge that could really support the primary care providers in not only during the visit of helping families and patients connect to the resources that are available to them in the community, but to also walk with them between visits, to give them somebody that's more available to talk to gain support, and to also point them in the right direction as far as resources go. And so I think it's real important that we look at patients and caregivers as people who have a huge reservoir of resources that we can tap into, not only to make us more efficient, but also to make it more effective. And so I think one of the things that we need to do in this arena is to really define some of the terms that we use when it comes to patient practice partnerships. We seem, at least in my world, seem to hear the words like partner and advocate and advisor used almost interchangeably, and so sometimes while we use the same words, we don't always mean the same thing. I think that's important for us to define those terms and those roles so that we're all having the same conversation. And I know, and we've had this conversation for years with different folks, that we really need to develop some meaningful measures to see the difference that engaging and involving, including patients and families and caregivers on our teams, that they really do make a difference, and that there's a measurable difference that includes efficiency, whether it's time or financial efficiency. And so we've got all the feel-good stories we need, and although those are great and they get people crying and laughing and encouraging, but they don't necessarily move that dollar needle. And so I think it's important that we look for ways to invest some dollars into studies that really measure that work. And then we just have to create a message that goes out to the public that says primary care is important because it is the best place for patients and caregivers to really have a voice in the care that they're receiving. And I think so many times we think of that care as being something that's done to us rather than something that we're partnering in. And so creating a message from a group that has great credibility will be really important, I think, as we go forward. And then the last thing that I would like to talk about is, and I'll do it just briefly, and you can read the slide, that just as we kind of use some terms interchangeably, we also mean different things when we talk about a partner or a family partner or a parent partner. And because of that, we have people in different parts of the country doing different work called the same thing. And so I want us, as we look forward to not only defining the roles that we're talking about, but also to have some established criteria so that we know when we're talking about a family partner, we know that they've been trained to work in certain areas and that they're receiving ongoing support in those areas. And some of those are emotional support the ability to discern where a patient or family member might be in the emotional process. We've seen that to be incredibly valuable, especially in the pediatric world, where parents, especially early in the process, are not always fully engaged because they're in a state of denial or they're angry or whatever. The next is the ability to just walk with the patient or family through the different seasons of life or stages of the disease process. And then, of course, families who have to engage the community know where the resources are, and they not only know where they are, but who you need to talk to really make things happen. And then the whole idea of family planning around a new situation that has come into your life is valuable, so that they have a direction that they're trying to go. And then teaching healthy communication strategies that allows everyone in the process to hear and be heard is really valuable. And then one of the great struggles that we see in our personal family as we deal with chronic illness of our child is just dealing with the other family relationships with cousins and aunts and uncles and grandparents that don't fully understand or appreciate the challenges that we face. And that can leave us feeling very isolated. And so having people around us that can help us through that are really important. So with those things being said, I'll hand it over to Bill and let him talk about priority number 4.
Well, thank you, Brad. As I think everyone knows on the phone, is that we can't achieve any of the above 3 priorities unless we have a very strong primary care workforce. And this is going to be a workforce that's properly trained in team-based care principles that are consistent with the patient-centered medical home, but also a healthcare workforce that is skilled in working with multiple healthcare disciplines in an interprofessional office setting. So if you picture our training programs in primary care across the country, does that sound like most of the training programs? And I would say, no, it does not. We are still training doctors to act autonomously to dictate patient care. Healthcare teams are often defined as simply a clinical support staff, either a nurse, LPN, or medical assistant with the physician. And we are very physician-directed and not patient-centered. So the priorities for number 4 are going to be to, if you start at the right, just building trusted teams to address these comprehensive needs, and then training the current and future. I mean, there's a lot of kind of faculty like myself who are out there, in their 50s and 60s, and we have never really been working as teams, and quite frankly need to be retrained and brought up to speed on this. And this will really work on helping the disparities across primary care as well. And then, as Brad said, including the patients and families, this is a no-brainer, but it really is so physician-centered, we need to really make it patient and family-centered as well. The how to prepare the workforce for team-based care is really promoting effective team-based interprofessional, and that's really the multidisciplinary healthcare professionals. As Marci was saying, it includes everything from behavioral health to social workers to pharmacy workers. Certainly advanced practice practitioners are all in there and really working in a team-based setting. We do need to develop a national strategy for this interprofessional education training that trains not only current but future trainees and patients and families as well. And then peer support, bringing that into primary care and communities to really bridge that gap into the neighborhood and the community. And then allocating funding for primary care clinical training. The workforce pipeline is quite long and very inadequately filled. We have an increasing need, as we said, and demand for primary care services across the United States. And these needs are like raging fires in our communities across the United States. And we show up with a fire hose that is extremely long, a minimum of 7 years long, 4 years of medical school, 3 years of primary care training. And the fire hose, it's hooked up to a fire hydrant, mainly our U.S. medical schools, that are only giving us a trickle of water. Less than 20% of graduating medical students go into primary care as a career choice. So we're showing up with this long, inadequately ready fire hose to put out all these fires across the community, and it's just not working for our communities, as many of you know, certainly in the rural areas as well. So we, as a PCPCC Education and Training Task Force, in 2011 developed these 16 interprofessional training competencies that I'll just show you here. And these are, we feel, are critical to preparing the health professionals across all disciplines to practice in these team-based coordinated care models, such as the patient-centered medical home. And these have really framed the expectations as we looked across the landscape across the United States, and as a PCPCC surveyed multiple programs, identified 7 really exemplar programs that we just published in one of our recent publications to show that there are programs out there doing this. And we, in addition to the map that Marci showed you of the science behind the PCPCC, we also have a database of now over 130 training programs that you can search for any of these competencies and click and make sure that if there's anyone in your area doing this, don't recreate the wheel. Please collaborate and partner with them. So I do encourage you to check out this database on the PCPCC website if you're in the business of training or future training clinicians. And as I said, the workforce preparation and training is such an important component of all of these priorities. None of us will be able to achieve that without that existing. And now I'd like to turn it over to Marci to talk about the current state of the PCMH and our future direction.
Terrific. Thank you very much, Bill. And Ken, I'm assuming that you can still hear me?
Yes.
Yes.
Okay, terrific. So where are we? Given everything that we've just shared, I loved Dr. Bill's fire hose analogy, because we are asking primary care to step up and resolve many of the major issues that our health system is grappling with. But it is true that we are still lacking adequate resources, adequate training, lacking an adequate patient-centered focus. Where we are then in the world of the PCMH is we are making progress. We are heading toward this tipping point, but we need to acknowledge that there's still pretty broad variation in terms of what a patient-centered medical home is, what sort of services it should be offering, how we can best implement it, and then what sort of evidence we should be requiring as a society to determine that this model is in fact successful. Having said all that, we believe at the PCPCC that there is an extraordinary opportunity, a rare opportunity for primary care to serve as this catalyst for health system transformation and indeed to serve as the leaders of this health system transformation. To do that work, we've got to be acknowledging some agreed upon definitions, and we need to be working together. We've got to decide how it is we're going to measure our collective impact, because to have an increase in resources to do this work will require an increased amount of trust that in fact we can do this, we are successful, primary care can resolve many of the major system flaws. So how do we measure that? We think we need to be measuring together the adoption of patient-centered medical home. So we need some standard definitions of what PCMH is. We start with AHRQ. There are a number of different accrediting programs that tell you whether you're a PCMH or not. We're very interested in working together with these accrediting programs to focus on transformation of practices and not just on meeting specific standards and checking boxes. Next, increasing that investment in primary care requires us to decide what primary care is and isn't. Many of us sort of know in our heart what primary care is, but we'll be working over the course of the next couple of years to define primary care in a more overt way, and then to set some standards, as Dan pointed out, who is investing in primary care and who isn't. How can we increase federal and state support for advanced primary care models? Those of you who track what Congress has been up to recognize that a pretty significant piece of legislation was passed this year in terms of the Medicare and CHIP Reauthorization Act, MACRA, otherwise known as the SGR, or Sustainable Growth Rate Fix. There are terrific opportunities to increase support for primary care within MACRA, and we'll be trying to influence MACRA's implementation just as we were in trying to get the legislation passed. Coming back to where the heart of the work really lies, it's in the practices themselves. So how do we prepare practices to do quality improvement work in a way that is truly patient-centered, and as I mentioned earlier, not just focused on getting an accreditation that may or may not result in true transformation for the team of healthcare professionals who work within that practice. And then how do we engage and align all of you across your broad interests to advocate for these strategic priorities? We too want to measure what engagement and alignment looks like. And so with that, I am going to end by telling you that we do stand ready to lead the charge, but let me be clear about what that means. Not lead the charge in any other way except facilitate the conversation and the dialogue. It's all of you who lead the charge in your practices and in your own organizations. We merely want to be the place where you come together and decide what needs to be done and how we can do that collectively. And we thank you, each and every one of you, for being a part of this effort. We consider it a movement or a journey. And so for those of you who are already members, we're grateful for that. For those of you who aren't or who are interested in an executive member sort of opportunity that would allow you to help us lead the PCPCC, much as Brad and Dan and Dr. Bill do, we'd encourage you to consider becoming an executive member and certainly attending our annual conference that starts November 11th in Washington, D.C. this year. We think they are terrific places for networking, but importantly for sort of invigorating you and thanking you for the work that you do. And with that, I'm going to turn it over to Amy Gibson. Amy, I suspect that there are a number of questions, and I know we don't have a lot of time, but if you would take the reins and facilitate a couple of the questions that are bubbling up to the top.
Yeah, absolutely. And if we don't get a chance to answer your question, we really will make an effort on our part to reach back out to you individually. And if we don't get to your question, please, again, don't hesitate to email us and ask more specifically, and we can carry on this conversation at the close of the webinar. But just a few questions that I've seen come up a couple times now. I'm going to offer up a few suggestions, and then Brad, I'll let you follow up with some other information. But we've gotten a couple questions talking about which organizations are really helping to engage healthcare consumers and patients in a real significant way on primary care change. And I think this is really important, and Brad, you certainly already spoke to this, but at PCPCC, we really are helping to and hoping to be a leader in ensuring that patients really are part of that change and healthcare consumers at large. There are some other great organizations that we partner with on a regular basis. The Institute for Patient and Family-Centered Care has some fantastic resources, education and training, not just for healthcare systems on how to integrate patients into that process, into governance, into policy making for organizations and in quality improvement. They've got a great website with resources that they offer. Plaintree is another great partner of ours. They're working mostly right now with hospitals, but they're starting to venture into primary care and ambulatory care settings. They're the ones who are really trying to figure out what are those key things that health systems need to do to change their model of care to be truly patient and family centered. Of course, we've got many of these resources and links on the PCPCC website, but Brad, you might want to offer up some other resources, especially as it relates to pediatric care, since you're working very closely within that space.
Yeah, in pediatric care especially, I think one of the organizations that's doing a lot of work around these ideas is Family Voices, and they are represented in every state across the country and trying to empower and engage families and also trying to speak into the conversation with care providers as to what it is that families are looking for. And needing. And then I think both AAP, AAFP, and a number of the provider organizations have really come on board in a great way and are asking families and caregivers the questions and at least engaging them in conversation to try to find out what's really important to families and caregivers and patients. And so the right conversations seem to be happening. We just need to be, in my opinion, valuing those conversations from a payer perspective so that providers actually can literally afford to take the time to learn what's really important to families. So we're excited that there is some movement in that direction, but needs to be a lot more.
Absolutely, absolutely. Because we are really short on time, Marci, I'm going to give you the last question. I think this is really intriguing and probably a question on the minds of many people in our audience. But it's around, why are we thinking that we need to target employers and employees around messages for patient-centered medical home? Why is that an important part of increasing access to patient-centered medical home and changing the way patients are partnering in primary care?
That's a good question, because we so often think if the healthcare system just fixed itself, then this wouldn't be something that employers and employees should even have to bother with. But I think it's unrealistic to think that we can expect the supply side of this equation to not get in the game. The demand side, the suppliers, that is the healthcare providers, need to understand that this level of care is something that patients, employers, employees expect, that they believe that they are entitled to getting primary care services through an advanced model like a patient-centered medical home, and that they ought to be paying for when they're paying for this kind of health care. That's what the healthcare system provides for them. We've worked for some time just in focusing on the supply side, and I think it's really important and motivating for primary care practices to hear from their patients, this is exactly the kind of care that we need, that we want, and furthermore that we expect, and we're going to help you demand proper reimbursement for it. So that reimbursement comes from employees saying this is the kind of care that we want to their employers, to their government, and I would suggest that we will be much more successful at promoting this model and diffusing it more quickly if we've got the payers in the game, the patients understanding what this is and arguing for it, and that we're valuing this as a societal good, as something that everybody cares about, instead of just something that the healthcare delivery system needs to care about. And with that, Amy, since you mentioned this as the last question, I'd reiterate that we want to answer everybody's questions, so people should not be shy in still sending them in if we didn't get to them. I want to thank all of our panelists for being a part of this important dialogue, and I hope everyone joins in and helps us as we try to move these 4 strategic priorities over the course of the next 3 years.
Thank you.